Hi everyone, today our topic is approach to DVT. Coming to the risk factors which are predisposing the patient for the formation of DVT are recently who are bedridden for 3 days or more, or major surgery within 12 weeks requiring general or regional anesthesia, medical hospitalization within the preceding 2 months, active cancer that is treatment ongoing within 6 months, or palliative, previous venous thromboembolic event. Recent trauma or fracture, paralysis, paresis, or recent plaster immobilization of lower extremities. Hereditary thrombophilia, example factor 5 lead-in, prothrombin gene 520210A mutation, protein C or protein S deficiency, presence of medical comorbidities. Physical examination assess unilateral leg swelling by measuring the circumference of the symptomatic leg 10 cm below the tibial tuberosity. Complete this with the asymptomatic leg. Any difference between the symptomatic and asymptomatic leg increases the probability of DVT, and a difference of more than 3 cm between the extremities further increases the probability. Coming to modified Wells criteria, the clinical characteristics such as active cancer, paralysis, paresis, or recent plaster immobilization of the lower extremities, recently bedridden for 3 days or major surgeries within the last 12 weeks, localized tenderness along the deep venous system, entire leg swollen, calf swelling more than or equal to 3 cm larger than asymptomatic side, pitting edema confined to symptomatic leg, and collateral superficial veins, previously documented DVT, alternative diagnosis at least as likely as a DVT. All the above clinical features get a score of +1 except an alternative diagnosis which gets a score of -2. The clinical probability of DVT is more likely if the total score is more than or equal to 2, and if the score is less than 2, the probability of DVT is very unlikely. Consider other causes for the patient's presentation, including a large or a ruptured popliteal cyst, which is a Baker cyst, or cellulitis, musculoskeletal trauma or injury, such as calf bleeding or hematoma, ruptured Achilles tendon, or ruptured plantaris tendon. Quantitative D-dimer level. Suitability of D-dimer testing depends on whether the patient's Wells score has categorized the patient as DVT likely, that is Wells more than or equal to 2, or DVT unlikely, that's Wells score less than 2, and the availability of venous ultrasound. Coming to a practical tip, if D-dimer testing is required, always order this before giving anticoagulation. A false negative D-dimer result can occur if blood is drawn after giving anticoagulation. If the DVT is likely, that is Wells score more than or equal to 2, venous ultrasound is the first line investigation for patients deemed DVT likely. However, request D-dimer testing if the result of venous ultrasound is negative or not available within 4 hours. After the D-dimer test, start interim in therapeutic anticoagulation and organize a venous ultrasound with the results available within 24 hours. If DVT unlikely, that is Wells score less than 2, because D-dimer testing for all patients categorized as DVT unlikely. If the D-dimer level has been taken but the result is not available within 4 hours, start interim therapeutic anticoagulation. If the D-dimer level is elevated, organize a venous ultrasound with the results available within 4 hours, or interim therapeutic anticoagulation and a venous ultrasound with the result available within 24 hours. A normal D-dimer level excludes a diagnosis of DVT. Consider alternative causes. Practical tip: be aware that an elevated D-dimer level is non-specific and is frequently abnormal in patients without DVT who are elderly, acutely ill, underlying hepatic disease, having an infection, or pregnancy. And coming to the summary, that is the common clinical symptoms which give us suspicion of DVT being a swelling, redness, pain, typically throbbing in nature and comes on while walking and bearing weight. Patients may also be asymptomatic, having had investigations for other conditions such as pulmonary embolism or malignancy. And we do check modified Wells score in these cases. And if the total score is -2 to 1, the DVT chances are very unlikely. And the score of it being between 2 to 9, the chances of DVT is very likely. And in patients with DVT unlikely, we go with high or moderate sensitive D-dimer test, and if the test is negative, DVT is being excluded. And if the test is positive, then lower limb ultrasound is done, and if it's negative, DVT is excluded. And if it comes positive, then treat it as DVT. If the chances of DVT are likely, lower limb ultrasound is done, and if it's negative, we have to consider an interim ultrasound or alternative imaging. And if the lower limb ultrasound is positive, we have to treat it as DVT. If diagnostic testing will take longer than 4 hours, begin interim anticoagulation treatment. The D-dimer blood test has high sensitivity, but it's not very specific. D-dimer can be raised in other conditions including malignancy, infection, pregnancy, post-surgery, inflammation, and trauma. And other investigations, order the following baseline blood tests before starting anticoagulation: full blood count, urea and creatinine, liver function test, clotting time, which should include PT and APTT. Do not wait for the results of these baseline blood tests before starting anticoagulation. Further assessment and investigations. An unprovoked DVT is a DVT in a patient who had no previous, a major or a transient provoking risk factor in the prior 3 months. Undiagnosed cancer. In any patient diagnosed with unprovoked DVT who was not known to have cancer, review the medical history, review baseline blood investigations including the CBP, the renal function and the liver function test, and the PT and APTT. Offer a physical examination. Do not offer further investigations for cancer for patients with an unprovoked DVT unless they have relevant clinical symptoms or signs. Agal cancer is present in approximately 3 to 5% of patients with an unprovoked DVT. And thrombophilia testing. Consider testing for hereditary thrombophilia in patients who don't have an identifiable risk factor and have a first degree relative who has had a venous thromboembolism if it is planned to stop anticoagulation. Do not routinely offer thrombophilia testing to first degree relatives of people with a history of DVT and thrombophilia. Consider testing for APLA in patients who have had an unprovoked DVT if it is planned to stop anticoagulation treatment. In practice, this is usually only done in patients if it under 50 years of age. And suspected concomitant pulmonary embolism. If patients have a confirmed DVT, do not routinely investigate for pulmonary embolism unless the patient has relevant symptoms or signs. If the patient had a confirmed proximal DVT, signs or symptoms of pulmonary embolism, and is hemodynamically stable, further investigation for pulmonary embolism is not needed because the patient will require anticoagulation regardless of whether they have PE. If the patient is hemodynamically unstable with signs of right ventricular dysfunction but pulmonary embolism is unable to be confirmed, diagnosis of proximal DVT justifies thrombolysis. Thank you.